everybody. We'll just give a second for folks to trickle in here. We just opened up. Okay, good. Well, why don't we go ahead and get started. Happy New Year to everyone. Welcome to the first Global Derm Talks of 2021. Today, we're glad to have Esther Freeman with us, and she's going to discuss her work in dermatologic manifestations of COVID-19 infection. So certainly a very timely topic in an area that she's been a key leader in. Briefly, Dr. Freeman completed her undergraduate studies at Dartmouth College. She then completed her PhD in infectious disease epidemiology as a Marshall Scholar at the London School of Hygiene and Tropical Medicine in the UK. She then came back to the States where she completed both her MD and her derm residency at Harvard Medical School. She's presently an assistant professor of dermatology at Harvard and also the director of the Global Health Dermatology Institute there. She's a member of the AD COVID-19 Task Force and directs the International COVID-19 Dermatology Registry, which is in collaboration with the American Academy of Dermatology and the International League of Dermatologic Societies. She's written 9 manuscripts already about COVID-19 since the pandemic began, and has really been a leader in our specialty in helping to tackle the pandemic. Esther was kind, or Dr. Freeman was kind enough to join us today while she's in clinic, so we actually have our talk recorded. But we're fortunate to have her come on towards the end for the last 15 or 20 minutes for a live Q&A session. So I'd encourage you to type any questions that you might have into the Q&A section, and we'll do our best to get to all of them at the end. And so without further ado, let me share my screen here and we'll put on her talk.
Hi. My name is Esther Freeman, and I'm the principal investigator of the COVID-19 Dermatology Registry. I'm also a member of the American Academy of Dermatology's Ad Hoc Task Force on COVID-19 and the chair of the International Alliance for Global Health Dermatology. I'm joining today from Boston, Massachusetts, and I understand we have a number of trainees in the audience, so I thought I would share a little bit about my story. My background is that I have a PhD in infectious disease epidemiology from the London School of Hygiene and Tropical Medicine, and then I proceeded to do my training and stay on as faculty at Harvard Medical School at Massachusetts General Hospital. Mentorship is very important to me, so I thought I would share some pictures from happier times. These are two of my medical student mentees at the last international conference that we went to in Mozambique before the pandemic started. And this is a picture from the Johannesburg airport with lots of international airplanes, which one day we will be able to travel again. So most of my time when I am not doing COVID research is spent as a global health dermatoepidemiologist. I'm an NIH-funded physician scientist, and I always think it's just nice to kind of share different career paths in dermatology for our trainees, just because there are so many wonderful options in our very varied field. So that's a little bit about my background, and then we'll launch right into the science. So I'm talking to you today about the COVID-19 Dermatology Registry, some of our early findings, and then overall some of the pathophysiology that we've come to understand, not just from the registry, but from other literature as well around COVID-19 and dermatologic findings. So for disclosures, the American Academy of Dermatology provides in-kind support for the Dermatology Registry, and the ILDS provides financial support for the COVID-19 Dermatology Registry. So at the beginning, well, I shouldn't say at the beginning of the pandemic, certainly we started hearing about the pandemic earlier in December and January, in December of 2019, but pretty early on in the pandemic, we started thinking about how to collect possible skin manifestations of COVID-19 and really also just capture the perspective of the dermatologic patient in COVID-19. Early on, we actually didn't realize that there would be so many skin manifestations. The first few reports coming out of China, there really wasn't a lot coming out about skin rashes, and it really took a couple of months until we started hearing some reports. We launched the registry back in early April, and I know this is dated August, but that was when the print version came out. So this is actually, this paper, which was about the founding of the registry, came out back in early April. So we founded the registry in early April with the idea of really being able to capture on a broad scale the dermatologic manifestations of COVID-19 and also understand the dermatologic experience. So for example, patients on immunosuppressives or other dermatologic patients we were caring for, what happened with them and COVID-19. So why launch a registry? What it can do is have very rapid global reach. And I like to compare this to kind of early days of the HIV epidemic, when we think about how we can bring together disparate observations from many different places across the globe. So early in the HIV epidemic, someone noticed a strange cluster of PCP pneumonia in a group of patients in California. And right around that same time, when they were publishing that report in the MMWR, there was also a strange cluster of young men who had Kaposi's sarcoma in New York. And so these were very disparate observations, which maybe by themselves didn't mean much, but this actually heralded sort of the first recognition of the HIV epidemic. And so similarly, the idea being that we can take disparate cases that may not mean much by themselves. So you might be sitting in Boston and see one case of something, or you might be sitting in Madrid and see one case of something. But when you start bringing those observations together, that's when we can make hypothesis generation. So that's the positive sides of the registry. I think it's also really important to understand what a registry isn't and what a registry can't do. So a registry does not replace good epidemiologic population-based data. So it's not a cohort study. It cannot establish the incidence. So what I mean by that is I can't tell you from the registry of everybody who gets COVID, what percentage are going to have skin symptoms. I can't actually tell you that from the registry. We can't establish incidence or prevalence from the registry. We also can't tell you a lot about causation in the registry. Now, we're very lucky in dermatology to have dermatopathologists who can really help us with a lot of mechanistic understanding. But I do think that it's important to think of the registry almost like a giant case series. So great for hypothesis generation, and great for bringing up scientific questions, but not great for establishing burden of disease necessarily. So in terms of launching the registry, we pitched the idea to the ad hoc task force for COVID-19 that I sit on in the end of March. And I feel very lucky that my team is a group of people who are very used to launching international databases and programming international databases. So we were able to very quickly, with the support of the AAD and the ILDS, to go ahead and code the database in about 48 hours, go through ethical approval, and go live just 9 days after we broached the idea to the AAD and then to the ILDS. So I think that this rapid pace really just emphasizes the overall international collaborative spirit that I think has pervaded the COVID-19 epidemic. People were really willing to come together and try to take a process that might normally take 6 months and really compress it rapidly, knowing that we needed to get information to the front line very quickly. So what does the registry look like over time? So as we mentioned, we launched in early April, and very quickly people started entering cases. And about a month after our launch, we were already up to about 500 cases. And now we are actually at over 1,200 cases in 42 countries. So truly an international effort. And we've been so appreciative of people entering their cases. I should mention that the registry is a provider-facing registry, which means that individual patients can't enter their own data. It's just healthcare providers. That does mean our number is a little bit smaller, but we believe it's higher quality data. As you have probably had the experience, if you call a patient and ask them to describe their rash, they might say it's red and itchy or has bumps. And it can be pretty non-specific. So we felt that it was important to have healthcare providers presenting the information rather than patients themselves, so that we could truly understand the morphology of what's going on. I think there's a place for patient-facing registries, but in terms of just trying to understand what these symptoms were early on in the epidemic, that's why we felt it was important that it should be provider-facing. So I wanted to talk first about one of the kind of more famous symptoms of COVID-19, at least in the dermatology world, which is Covetous. I would call them pernio or chilblains. And I've learned that this is where we get separated by a common language. I think in the US, we often call these pernio, and in the UK, often called, and UK and Europe often called chilblains. So a couple of papers here, and I just wanted to mention, I'm not sure if my little video box is going to block your photos. I'll try to move myself here. So I just wanted to mention, when you're looking at photos, I think it can be helpful to know when you're looking at a biopsy proven or lab confirmed case of COVID-19 versus a suspected case. So all of these pictures on this slide are all in lab confirmed COVID patients, because I know there has been some buzz of, do we really think this is related to COVID-19? So I just want to be clear that these patients indeed all had either PCR or antibody confirmed COVID-19, the photographs that I'm showing you here. We published our first paper after the first 318 patients from 8 countries were entered. We evaluated pernio-like lesions. And then we've also focused on this as well during our later paper called The Spectrum of COVID-19 Associated Dermatologic Manifestations, when we were looking at 716 patients from 31 countries. And both of these are published in the JAD. And as you'll see from these photographs, and probably from your own patients, I'm guessing many of you have experienced this with your own patients, is that it often presents, Covetous or pernio or chilblains often present about 1 to 4 weeks after COVID-19 infection, tends to travel with very mild disease, and we'll talk a little bit about why. And it tends to be very kind of, it starts off as red and swollen, and people describe a burning, itching sensation. And then they usually go through that for about a week or 2, and then it will turn more violaceous or purple, and often the sensation starts to improve. So the purple color may last longer, but the sensation starts to improve. All right. So I also wanted to take a moment to really point out that skin of color it's really, really important that we spend time thinking about how to recognize different skin conditions in skin of color, and that different rashes can present or look a little bit different depending on the skin tone. So I'm very appreciative of this paper, which has some images of what pernio and chilblains can look like in darker skin tones. And I think it's really important for how we're trained in terms of pattern recognition to appreciate the erythema and the violaciousness in these images as well. So I think it's important to take a moment, especially when we consider which communities are being really hardest hit by the COVID-19 epidemic. So I think this, to me, this paper here is what I would call kind of the smoking gun. So this is a paper published in the British Journal of Dermatology by Colmenero et al., where they looked at 7 children and who were SARS-CoV-2 negative in their nose. So they were swabbed for their nose and their throat. They were PCR negative, not because they didn't have COVID, but because by the time they developed the toe lesions, it's usually after the acutely infectious period. And they had skin biopsies done. And so this picture here with the little white arrow is showing an electron microscopy image of a coronavirus sitting in someone's toe. So I think that it's just important to realize that SARS-CoV-2 is directly involved with a lot of these patients. Not that saying that everyone who happened to get pernio or chilblains during COVID-19 was all caused by COVID. So for example, if you were walking barefoot in the snow, you might have another reason to get pernio or chilblains. I think it's important to have common sense prevail. But for our patients, for many of our patients, is directly linked with their SARS-CoV-2. So on pathology, when you biopsy patients with pernio or chilblains as a response to SARS-CoV-2, also known as Covetous, you basically get findings that look pretty much like run-of-the-mill pernio. So they have vascular changes, some immune deposits. There may be an occasional thrombus or 2, but it's really not a clotting pathophysiology. It's an inflammatory pathophysiology. So I think there's a lot of kind of information around testing for COVID-19 and people wondering, why aren't all these patients testing positive when they get Covetous? And so I wanted to kind of delve into that a little bit, because timing of testing is really clear. When you test and exactly what you're testing for, I think is really important to understand. So I think the key thing is that most patients who develop pernio, chilblains, or Covetous develop this after their acute infectious stage. So many cases 1 to 4 weeks after they've had COVID-19. So most of our patients we would expect to be PCR negative because often PCR positivity may only last a few days or a week. Now, in the registry, 15% of our pernio cases test positive, PCR positive for COVID-19, because there are some patients who develop it relatively quickly in relation to onset of COVID-19, and they may still be infectious. And then there also may be some patients who continue to have PCR positivity for a long time, even after their infectious period. So people often ask me, should we test Covetous patients for COVID? I mean, in general, I am in favor of testing in general, right? We should have a lot of access to COVID testing in general. I think it's a good way for all of us to know our status and to get repeat tests. So in general, I'm always a fan of people getting tested regardless. But I do think that if your patient has developed Covetous in the last 7 days, I think it's reasonable to get them PCR tested because you don't want to miss a patient that is still potentially infectious. Now, if they've had their purple toes for like 3 weeks by the time you see them, the likelihood that they're infectious in that moment is much less. So that's my general feeling, is that you don't want to miss the PCR positive patients. But the reality is that in many cases, this will be after the acute infection. So let's look a little bit more into this issue of timing. And this is one of our more recent papers published in the JAD on timing of PCR and antibody testing in patients with COVID-19. And for a moment, I'd like you to focus in on the graphs on the left of your screen. I'm sorry, realizing depending on how I point on Zoom, it may be left or right, but on your screen, it should be on the left. And so on the y-axis, you'll see number of patients. On the x-axis, you'll see time. The green bars are PCR positive cases, and the red bars are PCR negative cases. So these were people who were tested by PCR and who were negative. The vertical dotted line is the onset of dermatologic symptoms. So what I'd like to point out is the patients who test PCR positive, median time for PCR positivity is within 6 days of their onset of dermatologic symptoms. So basically, you need to test them pretty quickly after onset of dermatologic symptoms if you're going to find a positive PCR. In contrast, patients who had a negative test on median were tested 14 days after the onset of dermatologic symptoms. So you're certainly much more likely to have a negative test if you're tested later. Now, this isn't without bias. It's certainly possible that people who were sicker or more likely to have COVID might have been able to access a test sooner. But I think it gives you the general gist that the timing of your testing is very important. Next, I'd like to bring your attention over to the right side of your screen. And what you'll see is here, the green bars again are PCR positives, and the purple bars now are antibody positives. So what you'll see is that mean antibody positivity was noted around 30 days. The reason I bring this up is that early on, people were starting to test antibodies very rapidly, like 2 weeks, in a couple of different papers. They tested patients at 15 days after their onset of dermatologic symptoms for antibodies. And they said, oh, they're not there. The patient never had COVID. Well, 15 days, we really don't expect a lot of people to have antibodies. And it's even more complicated than that in terms of antibody timing. And we'll get into that in a second. So I do agree with the Infectious Disease Society of America guidelines, which is that you should probably wait at least 3, possibly 4 weeks before antibody testing someone. And I also would point out that antibodies change over time. So just one antibody test given at one point in time may not give you the full picture. Things get really complicated when we think about mild COVID-19, and this is where Covetous comes in. Most of our patients with Covetous have really relatively mild courses of COVID-19, and there's a reason for that we'll talk about. But what's tricky with mild COVID-19 and antibodies is, number one, that a lot of our patients with mild COVID-19 may not actually mount a significant antibody response, because they're actually using robust T cell immunity to control the virus. So it's not necessarily that they are eliciting an antibody response, and the antibodies are not necessarily the way that they're controlling the virus. It's actually through their T cell response. So many of our patients may actually never develop an antibody response even after COVID infection. And then additionally, we have evidence that patients who have relatively mild disease can have very rapid decay of their antibodies. So the antibodies may not last very long. So if you don't catch them in that exact moment, you might miss them. This to me is one of the most important papers that has come out in the last 6 months. And I really love this paper by Hubice et al. This was just published recently in JAMA Dermatology, I think in November or December, titled Clinical Laboratory and Interferon Alpha Response Characteristics of Patients with Chilblain-like Lesions During the COVID-19 Pandemic. And I think what's so interesting about this paper is that they found that patients who had chilblains in this setting had a very high interferon alpha response. And that it was actually very similar to a type 1 interferonopathy, which can be a genetic condition. So not, and that this, I think that we just need to unpack this for a moment. I think this is really interesting. I think that what we're seeing here is that interferon plays a really critical role in the development of pernio and chilblains in the SARS-CoV-2 epidemic. And then what they did is they actually compared the interferon response in patients with chilblains to the interferon response in patients with moderate or severe COVID-19. And interestingly, the patients with chilblains had a much higher interferon response. And we know that patients with really severe COVID actually have a blunted or muted interferon response. That may partially be why they're so sick. So what's so interesting here is that this actually really explains so much. It may explain why often we are not necessarily seeing high levels of antibody production in our patients with Covetous. They've basically mounted a really robust interferon response. They've basically reacted in a strong way through their interferon response to the virus. They've brought it under control relatively quickly, and infection basically can be cleared before humoral immunity kicks in. So I think this is a really important paper when we're starting to think about really understanding the pathophysiology of Covetous. And I think it also opens the window for some possible treatments as we start thinking, and this is something that we're actively trying to think about, which is how do we treat this interferon alpha response, which was helpful for the person, right? You wanted them to have a robust interferon response and you wanted them to control the virus. But now it's effectively left this kind of side effect of their interferon response, which is their pernio or chilblains. And in some of our patients, that's lasting an awfully long time. I did want to mention one thing. I'm just going to go back to the slide about antibodies for one more second, that I wanted to just mention that when you do commercial antibody testing, you are usually testing for IgM or IgG, and it's usually just the spike protein. But Hubice's group, which is the same group that published this paper in JAMA Dermatology, found that, and there's actually been several papers on this, have found that interestingly, if we can detect antibodies in these patients, so if they do make some small amount of antibody, it actually tends to be IgA, and it can come and go very quickly. So I would just remind you that when you're ordering an antibody test, you're probably testing for IgG or IgM of a spike protein, and you're not testing for IgA, which is in many cases the antibody that these patients are producing. So I think it's either this paper by Hubice or the one that he published in Lancet Infectious Disease, where almost 30% of the patients actually had IgA positivity. So it's a small point, but I just want to remind people that not all antibody tests are the same. So even if you look at an antibody test that says 97% specificity or sensitivity, that's great, but it's only testing for IgM or IgG in that particular spike. It's not testing for a range of different things that you might be making antibodies to. So I just wanted to bring that up as well. This is also a great paper I just wanted to mention in the British Journal of Dermatology by Magro et al. Also talked about the interferon response that they found in their patients as well. So 2 different papers talking about the type 1 interferon response. So in case you wanted another good read. Ooh, so that was a lot about interferon. and we're all still learning together. The next thing I wanted to talk about is the duration of dermatologic symptoms in COVID-19. So we've heard a lot about long haulers in other fields. We've heard about patients who are having persistent neurologic symptoms. We've heard about patients who are having really persistent loss of smell and taste. And we're hearing about patients who have longstanding cardiac issues from their COVID-19. So I think it's really, this brought up the concern, is this happening in dermatology as well? And really when my patients started coming in with dermatologic symptoms after COVID-19 that had been lasting, 6, 7, 8 months, which is really when we started focusing. So this was certainly picked up by the media, which I think is helpful for people just to be aware of the issue that long haulers exist in the skin and as another organ system, and not just, for example, in cardiovascular or neurologic symptoms. So something else to keep your eye out for. And I think one challenge that we're having, and why I'm so interested in the interferon papers, is thinking about these patients that may have some sort of prolonged interferon response. How do we treat them? So something I'm really struggling with, and certainly happy for anyone's thoughts. I would also say I think that a new group of patients that we're seeing that's very interesting are patients who had COVID in the spring with the first wave, improved during warm weather, and then when they were challenged again with cold weather, they've actually gotten pernio again. So this raises, we've tested these patients, they haven't necessarily gotten COVID again, but it seems that the cold weather has kind of triggered that inflammatory response again. So that situation, we are actually now collecting those cases in the registry. So if you have a patient who's developed recurrent pernio in this setting, we're happy to hear about them, and please do enter them in the registry. But I think it also raises the question, when we think about recurrent pernio outside of COVID-19, when we've just seen recurrent pernio in the community in the past, it does make me wonder, was some of this actually virally triggered in the past? Is it possible patients with recurrent pernio actually had some kind of interferon response that was triggered by a prior virus? Probably not in every case, but it may be in some cases. So I think it makes us actually rethink pernio pathophysiology as a whole. All right, that was a lot about pernio. I know we snuck in some other, duration of COVID skin manifestations. So I wanted to spend a lot of time talking about that. And then also just to mention some of the other cutaneous manifestations of COVID-19. So this is our paper that looked at the full spectrum of COVID-19 associated dermatologic manifestations. And so if you look at the registry overall, I would just point out this first number I've circled in red is that about half of our cases are entered by dermatologists, which also means that half of our cases are not entered by dermatologists. This is actually a good thing. So when we created the registry, think about, especially in the beginning of the COVID-19 epidemic, think about who was seeing the COVID patients. It was not necessarily the dermatologists. It actually takes a lot for a patient with COVID-19 to end up in a dermatologist's office, especially early on in the pandemic. It was often our frontline care providers. It was those in the emergency department. It was those in the intensive care unit, for example. And so it was really important for us to get the word out for our frontline providers to enter the cases that they were seeing. So I'm actually really pleased that we were able to do that. The next thing I'll point out that I think is a huge limitation and a problem is if you look at the patient race and ethnicity entered into the registry. So at the time of this analysis, 80% of those patients were white. But if you think about the burden of COVID-19, it has primarily been in people of color and skin of color populations. So the registry really is not representative of the overall COVID-19 epidemic. And we've really been working on outreach and advocacy to try to get people to be aware. And I think this is, I suspect this is a multifactorial issue. I think patients in certain areas may not have great access to dermatologists, may not have great access to healthcare in general. It also may be that without images that look like them, patients may not necessarily recognize some of these skin rashes, and providers may not recognize some of these skin rashes. So I think there is a lot to be done in this area, and I just wanted to particularly highlight that as a problem. You'll also notice that most of the cases, at least early on, were from North America, which is certainly where we have our largest presence, about 89%. And I think we've continued to grow internationally, but that's also a point that we're now in 42 different countries, but still most of the patients that I'm talking about come from the United States. All right, so that's kind of what's in the registry. What are the big culprits? So we've already talked about Pernio, which is most commonly reported in the registry. It's second most common reported when you limit to lab confirmed cases. Morbilliform is certainly our most common lab confirmed eruption. And I think that's not too surprising. If you'd probably asked me before all of this started, if there was a new global pandemic, what was the one rash you would expect to see? I think most dermatologists would say morbilliform. And we're certainly seeing lots of urticaria, some macular erythema, vesicular eruptions. We see Grover's like, which is separate on here, but I actually think the Grover's and the vesicular may be one and the same, because we're starting to see some biopsy reports that I think what some people may be calling vesicular may be very similar to what other people are calling Grover's like eruptions. And then we're also seeing in our more severely ill patients, Retiform Purpura. And I wanted to talk a little bit about the spectrum of disease, and a big shout out to Joanna Harp, who's a dermatologist based in New York, for her help with this figure, because I think she really helped us kind of explain the true spectrum of disease. So if you take a look at this arrow, on the left side in green is our less severe COVID-19. And as the arrow gets more red, it's showing our patients who have more severe COVID-19. Here we define severity of COVID-19 based on the percentage hospitalized. So on one end of the spectrum, with Pernio or chilblains that we were talking about, only 16% of our patients were hospitalized. And as I mentioned, this is probably because Pernio is almost like a side effect of a robust host immune response and a robust interferon response. Now, if you go all the way over to the other end of the spectrum, you'll see Retiform Purpura. Now, Retiform Purpura, 100% of our patients were hospitalized and 82% had fulminant respiratory failure. And now this is very different from Pernio or chilblains. These patients are really actually clotting, right? And so they're clotting under their skin and they're clotting in other areas as well. So that's more of a thrombotic event. So that's very different. So I just wanted to show you the full spectrum and how not all rashes in COVID-19 are happening in the same way. And then in the middle, we have this bigger group with urticaria and macular erythema and morbilliform, where there's a bit more of a range of different severities that are occurring. So overall, I wanted to say a huge thank you to the team that is involved. It really takes a lot of people to manage the registry and to work through the details. And so a huge thank you to my co-investigators, to my registry data governance work group that's helped me through this, and especially to the AAD and the ILDS for supporting this. And to all of you, I think many of you have entered data in the registry, and we're so appreciative because really together, our goal is to provide real-time data analysis as quickly as we can back to the front line and recognize different symptoms of COVID-19 and really understand how dermatology can help in this epidemic. So with that, I will just say thank you for this opportunity. It's been a wonderful chance to get to talk with you today, and I will be open for questions. Thanks.
Great. Well, thank you, Dr. Freeman, and also welcome. We appreciate your time today and the wonderful talk. It's really impressive how rapidly the registry came together and all you've been able to accomplish from it already, and how powerful a tool it will be moving forward. I just want to open up the Q&A here, which I apologize was hidden from me, so I didn't have a chance to preview during the talk.
I'm not sure if it's just me. Can you guys hear William?
Are you able to hear us okay now?
You're just like very soft, William.
Yeah, you're kind of quiet. Can you get a little closer?
Oh, sorry, guys. Okay.
Thanks.
Great. Okay, so moving on to the Q&A portion. So the first question is from Anne Rothstein, and the question is, what percentage of Covetous patients are seropositive?
Okay, great question. So by seropositive, well, let's actually just talk about Covetous and testing in general. So great question. I think one thing to think about with Covetous is that and first of all, hi, I should say. I hope you guys are able to hear me because I'm like double masked and our clinic rules are that I can't take this off. So we're just going to go with it, which is why we need to record it, because that way you can at least see my face. So I'm like in the middle of clinic. So thank you guys for bearing with me, and you get to see the inside of MGH Derm, which probably looks like pretty much every other derm office anywhere. So first of all, like, total delight to be with you guys, and hopefully you'll be able to like hear me through my many layers. So I think, what's really interesting about COVID testing and Covetous is that patients, as we know, it happens about 1 to 4 weeks after COVID. So people are not necessarily PCR positive. And in the registry, as I think I mentioned, about 15% of patients in the registry with Covetous are PCR positive. So, which means 85% are either were not tested. And in early days, like very few people were tested. So I don't think you can say 85% of people were negative. It's more just, that's a combination of not tested and negative. And then there's also, keep in mind that when you test really matters. And I showed that graph showing that like when you test in relation to onset of dermatologic symptoms, it has a huge impact. So anyway, but what you can think about is about 15% in the registry are PCR positive. And that's kind of assuming you test pretty promptly. And so people often ask me, and I know I'm going to get to the antibody question in a moment. So people often ask me, should I PCR test this person who comes in with their, pernio? And I say it kind of depends. If it's new onset, they've never had a history of pernio. I mean, I really don't, if someone's like had a lifelong history of recurrent pernio, I don't know why you would think that that's related to COVID. I mean, that to me is like, okay, they've already had recurrent pernio. Similarly, if someone's been like outside walking in the slush, barefoot, you might have another good reason for them to have pernio. So I think common sense prevails. But, without that, someone comes in, new onset pernio, no other reason to have it. I think if it's within the first week of them getting the pernio, I think it's reasonable to test, because in that group, there probably is a chance you may get a PCR positive. Once you get past like 10 or 14 days, the likelihood that that person's still going to be PCR positive is incredibly low. And I really view it much more from the public health perspective of like, our goal is to stop the virus and to stop a viral transmission event. Like that's what really matters, right? In terms of big picture. People also say like, well, maybe I shouldn't test. And I'm like, well, in the world we live in right now, I get tested every week, so I think the bar for testing at this point is very low. Like if anybody crosses your mind, you should test, because we could all be, just getting exposed in the grocery store or wherever we are or ongoing. So I think that's my general feeling about testing. Now, in terms of antibody testing, to unpack your question a little bit about what percentage are antibody positive. So this actually really varies depending on what you're testing by. So I'll point out that not all antibody tests are created equal. And I think, and I'm going to kind of sidestep and kind of answer your question, but if you actually look at, for example, the Hubite papers, which was in a cohort in France, but there's actually multiple other papers that have now shown this, is that most of our patients with Covetous are actually IgA positive, but IgA is not tested on antibodies. So can I truly tell you what percentage of our patients are antibody positive? No, because most of them were tested for IgM or IgG, and we know it's actually IgA in this patient population that becomes positive. And then I think what's so interesting, sorry, then I'll stop talking and we get to our next question. I think what's so interesting about the recent interferon data is that it's really suggestive that patients are actually having this super fast and robust response. They may never get to the point of making antibodies, but if they do, it's probably IgA, and it's probably for like a hot minute. So, I think it's just an interesting conundrum. I think every time I think I understand what's going on with pernio, it's like this onion that we're peeling. And I think it's so tempting for someone to be like, my patient has negative PCR, and look right here, a negative antibody test, and it says it's 98%, sensitive and specific. And you're like, well, it is, but if you're testing for the wrong thing, it could be as sensitive and specific as you want. It's still going to be negative. So I think that's just something to keep in mind. So I'm always looking at patients. I'm like, well, it may be, by the way, this testing that we have commercially may be negative. And I usually try to end up getting them an IgA if I can through a research study, but not available commercially.
That's great. Thank you. I have a quick follow-up, and I think there's a follow-up in the crowd to that as well.
Thank you. Well, can you get a little closer? I just really have a hard time hearing you. I'm sorry.
Double check my microphone here. Do you have any recommendations of whether it's worth testing patients using commercial panels at this point? And is there any evidence that, or is there an IgA commercially available test coming along?
Yeah, so not that I'm aware with IgA, I will say I do test my patients because I think it's helpful for them to know. And I do have several patients who are IgM and IgG positive. So, and I've had some patients now, and I will say we talked about long COVID. And I will say 2 of my long COVID patients that I take care of, so they got COVID in March or April. One of them end of March, one early April. And like we know they had COVID, you know, one of them, her father was in the ICU and almost died, and the whole family tested positive. She never had COVID. Her toes turned purple when she got, about a week after she got COVID, and they've stayed purple. So they've been purple and painful at this point for 10 months. And she'd never been antibody tested. And I was like, well, I saw her, 2 weeks ago, and I was like, well, let's antibody test you just to see. Like, we already know you had COVID, and I kind of assumed it was going to be negative. Where here we are, we're 10 months later, and she was positive on just like a regular Viacor, like totally standard antibody test. So you do still get some positives. I don't think I could tell you, the registry is not good for incidence or prevalence because it's really just like a big case series. So I couldn't tell you how common that is. But I will say I've had 2 recent patients, both of whom had these like very long hauler symptoms, who actually remained antibody positive. It's also hard to counsel patients. What does that mean? So like, are you going to change your behavior now? I mean, I still tell people to wear a mask. So, but I still feel like it's kind of nice to know.
That's great. Thank you. And then the second question, which was from the audience, was it's about autoantibodies. So I'm guessing that's referring to ANA, but I think there's also some evidence now that patients may be developing antibodies to other things like.
Yeah, very true. I think this is super interesting areas. That's a great question. I actually do. So on my pernio patients where they've just developed pernio like acutely and subacutely in response to COVID, I'm not doing like a huge workup. Just because most patients like it resolves and they kind of move on with their lives, and I don't think we need to necessarily go too crazy. I mean, at the beginning of the epidemic, I was, because we were just so confused about what was happening. I've kind of stopped doing that, but there's 2 situations in which I am actually now doing a more extensive autoantibody profile, and I have referred a few people to rheumatology. I have a COVID rheumatologist here. So the 2 situations that I do that is, one is someone who has prolonged or long hauler COVID. So like my patient I just mentioned, who's had purple toes for 10 months since her whole family got COVID. And so I did do, because I'm kind of wondering now, like, why is this still going on? So I have done pretty extensive autoantibody panels on that group of patients where they have long symptoms. I've also done it on patients with this new kind of recurrent pernio that I mentioned, where they got COVID, they got COVID toes, they got pernio. They did pretty well over the summer, and depending on where you live, you may not have as much seasonal variation as we do here in Boston, but in Boston, it was like very warm and nice. People's toes kind of got better, and it was so interesting. It hit like November, and it got cold here, and all of a sudden my office was like full of people who were like, why are my toes purple again? And they've never been, and to be clear, these aren't patients with like a prior history of recurrent pernio. These are all patients who never had pernio in their lives. They got COVID, they got pernio, they were fine over the summer, and as soon as it got cold. So I do strongly believe that there's a little bit of a double hit going on. And I think it's very interesting. Sorry, I'm like a little off topic, but you can see I get very excited about this. It's very interesting that if you look at the type 1 interferonopathies, so having dug into those papers a little bit, because now like I never like thought about type 1 interferonopathies. Ooh, I'm like steaming up my glasses here. So with the type 1 interferonopathies, interestingly, even there where it's a genetic predisposition, they're cold sensitive. So, there's clearly some sort of funky interaction here between the interferon, the temperature. So anyway, that group of patients where they're getting recurrences, I have been working up as well, just because it makes me wonder, like, is there some sort of kind of autoimmune triggering going on? And we're seeing that, of course, that we're all seeing autoantibody conversion in COVID patients with things that are not skin, right? We're seeing a lot of that. Now, I've actually not had anybody convert to ANA positive, but what I have been seeing is, interestingly, anti-smooth muscle antibody. And I don't know why. That's in theory and sometimes associated with hepatitis. All my patients, their livers have been fine. I sent a bunch of them to rheumatology, who was kind of like, I'm not sure what to make of it. I've not had a lot of like cryos positive or anti-phospholipids positive. So I do think that there is something, and it kind of makes me wonder if some of these patients are brewing, clearly some sort of autoimmune situation, but I don't think we have a good handle on it yet. So I'm very happy to hear from the audience if some other people do. Because I've been looking at this, and besides the anti-smooth muscle antibody, I haven't been having a ton of that. So
Great. I think I'm going to take over for Bill. Can you hear me a little better?
I can hear better. Sorry, I don't want to get my ear like quite so close. Thanks.
Sorry. Great. Well, thank you so much again for giving this talk. It's super interesting. And I completely agree. As someone who studies autoimmune diseases, I think this is like, I mean, unfortunate for patients, but fascinating to actually see happen, like what, the virus is breaking tolerance and causing all these autoantibodies and other autoimmune conditions. So another question that we had, could hypoxia be an underlying mechanism for pernio in COVID patients' extremities?
Well, most of our patients who get the pernio are in really mild disease and never got hypoxic. So, I mean, could there be some like tissue level hypoxia? Maybe, but I don't think that's the major mechanism.
Also wondering if the dermatologic symptoms correlate with COVID severity or coagulation tests during post-COVID.
Yeah, great question. So that's with a kind of that, I know that question popped up before I showed that spectrum diagram, so I may have kind of answered it, but we do see that there is a big variability. And so like pernio or Covetous is on one end, we think interferon mediated, patients have very good control of the virus. Only 16% of those patients were hospitalized. At the far, and that's not coagulopathic, I'll point out. Like occasionally you can find like a little thrombus in there, but that's not what's causing it, it's inflammation. Now in the total other end, you have Radiform Purpura, which is coagulopathic. So these are people who are clotting, and what you're seeing in the skin is probably just, indicative of clots elsewhere. And those patients, 100% are hospitalized, 85% are in fulminant respiratory failure. So for sure, there's like a big variability. And I remember back, I mean, it's funny thinking about how the questions have changed over time, because I ended up doing, working with the media a lot in the beginning when we were first noticing these signs and symptoms. And in the beginning, people were really, so we just were starting to hear about, if you think, you have to like turn yourself back, it's amazing how far we've come, but we were just starting to hear about pulmonary emboli, and we were just starting to hear about like clotting, like in the beginning of the COVID epidemic. And people were very worried that these purple toes were actually going to turn out to be clots, and they're not. I just want to like reassure people, this is like an inflammatory process, interferon mediated, quite different than clotting. But it's interesting because I think it's taken us some time to like come to that.
Great, thank you. And the next, are you starting to screen for COVID via PCR for patients with unexplained hives or other rashes?
Yeah, it's a great question. So it kind of depends on the scenario, but I do. If someone comes in with new onset urticaria, I mean, you got to do a history. Like if they just had shellfish last night, and now they have a rash and urticaria, and or there's something that they're allergic to, or they just went over to like their family's house that has like a cat or a dog or something. So I mean, you got to do a history. You can't just be like, oh, urticaria, like I'm gonna COVID test. But I have sent a number of patients over. I actually, I was just thinking about this morning. I've sent a number of patients over, and I've actually diagnosed COVID in patients with new onset unexplained rash. Now, I mean, as dermatologists, we are able to break that down a little bit, right? So like urticaria would make me think of it. If it's like a morbilliform, viral looking eruption, like definitely. I mean, I would do a drug history. If they just started a new medication, you may have another reason. So definitely talking to the patient, getting a good history. But, if I saw new onset morbilliform without another reason, new onset urticaria without another reason, those to me would be like, let's get you tested ASAP. Now, keep in mind, and I've actually, we diagnosed patients with COVID that way, where their presenting symptom was a rash. But also keep in mind, again, my threshold for testing someone is very low. Like if we could all get tested every week, everybody, that would be great. So I don't think you need to have like some huge, massive reason to go send somebody for a COVID test, right? Because of how much asymptomatic disease there is around.
Great. I think the last question, do you have any particular types of cases that the registry is looking for, like long haulers?
Yeah.
Or do you still want people to enter run-of-the-mill Covetous?
Yes, I would still love it. So thank you. So we actually love everything, because there are a lot of sub questions that we can dig into. As you saw, like every time I write a COVID paper, I'm like, oh, this is the last COVID paper. And I have said that like 6 times, because every time like something else happens, and I'm like, oh man, like there's this whole other phenomenon we got to look into, like for example, timing of testing. Now we're doing long haulers, we're doing recurrences. So, but even with what you guys are calling like run-of-the-mill Covetous cases, like is actually helpful to us because we can look potentially at like the types of antibody testing they might be having or PCR. And so, and then also like racial disparities and geographic distribution and also time of year and temperature. So there's like a lot. So even if it seems like, oh, this is like a boring, I wouldn't call it a boring case, but even if you're like, oh, I know this case is like many other cases they know about already, like please go ahead and enter it because it's actually still very helpful for us. And then in particular, so pretty much any COVID derm manifestation, like put it in there, we would love to see it. And then in addition, any recurrences that you're getting, any long COVID that you're getting, and then our newest thing that we launched, and I'm not sure if I mentioned this in the presentation, but is that as of 2 weeks ago, 3 weeks ago, we went live with collecting COVID vaccine reactions. And so this is, something near and dear to my heart. So now we're no longer just collecting COVID dermatologic manifestations, but we're also collecting cutaneous vaccine reactions. Now we know like something like 80% of people are going to potentially have like a vaccine site injection reaction. And we're very happy to see those. So even if it's just an injection site reaction, like tell us about it. And then we're obviously also happy to hear about, you've heard about the filler reactions that are happening, but we've also are just seeing like, I find it very hard to describe. So I'm very interested to get more cases. We're seeing people with this kind of more, almost like a hypersensitivity rash. I almost don't even quite know what to classify it. It doesn't quite look urticarial. And people are getting it not just in the arm, but they're getting like more of a full body diffuse rash. So I think as more people get the second doses, and sometimes people seem to have like a little bit more of a robust response to dose 2, I think we may see more of that. So please do enter your cases, or if you have colleagues or friends who got the vaccine, have had a rash, just encourage them to do it. It's the same website, it's the same registry, and we've changed the front page to make it look a little more obvious that like, yes, you can put vaccines in here, and it's pretty quick. The vaccine one is like, it probably takes about 2.5 minutes.
Awesome. And we had one last question pop up also from Anne. You mentioned there's infiltrating T cells in the skin. Do they persist in the long haulers? And if so, do you think they could be autoreactive?
That's a great question. And the probably very short answer is we don't know. I think that's a great question. I am so intrigued by these long haulers. I mean, for me, it was just like reporting that they existed. And recognizing that they existed was kind of a thing, but I don't, I've biopsied a couple of them, but I'm very, I think this is a super interesting group of patients, and I have a cohort of them that I take care of here in Boston, and it's very, I will say on a personal level, it's very, gratifying to take care of them, but also very frustrating because right now I can't offer a lot. And so I certainly, I'm trying to think outside the box now about, I've tried a couple of them who were really, really in pain after 10 months. I've tried putting on Plaquenil with very mixed success. We've tried topical compounded gabapentin and topical compounded diclofenac together, which has worked pretty well, but not an answer. It's just like a Band-Aid. I'm starting to think about whether JAK inhibitors, could be helpful. A lot of these patients are a little bit hesitant about systemic medications, and topical compounded JAKs are expensive. So I'm actually very open if people have thoughts, which doesn't answer the T cell question because the short answer is I don't know. I would love to know. And if you have thoughts on how to study it, please let me know. But I'm also interested in people's thoughts on treatment because it's tricky.
I mean, do you think tacrolimus would be an option or no?
Yeah, listen, at this point, I'm like, sure. So I don't think that's a bad idea. I'm going to write that down. Yeah, I don't think that's a bad idea. I mean, honestly, these patients are really, I think what's so nice is that they're very willing to, I don't want to say experiment with me because we're not like experimenting on them, but just try different ways, because I think what's hard is, I think people are reassured when they've been struggling with this for 10 months and people are like, there's no way, why have you had this for 10 months? I think people are reassured to find out, I'm like, oh, you're patient number 13. And they're like, oh, okay, it makes people feel better. Like, okay, I'm not alone. So I think that's the first thing. But people are very willing to try things for like a month and just see, because they know that we don't really have all the answers right now. So
awesome. Well, I think you need to head off for your clinic.
I got patients.
Yes. Okay.
So well, probably some more toe patients, but it was awesome to chat with you guys, and hopefully you can still hear me with everything.
It was great. Thank you so much for joining us today. For all your work.
Yeah, absolutely. All right. Bye, guys.
Thank you. Bye.